with over 60 years' experience caring for patients, residents, and healthcare professionals. As the mobility experts, we're committed to shape a better future where healthcare professionals are empowered to drive healthier outcomes for their business and for the countless people who depend on them. People are made to move. Through the right equipment, environment, and skills, we offer the ability and confidence to always deliver quality care, today and tomorrow. This is our focus, our cause. Arjo, empowering movement.
So welcome back from the break. So far today we have touched upon several pressing issues for global health, and it is clear that there is a need for transformation. But the question is how, of course, as always. And it will not happen unless collaboration accelerates, right? And during this session, we will keep our eyes at the future. It's called Co-Creating Health and Care 2030, so not so far away, actually. And we will meet researchers and industry leaders with hands-on experience on transforming healthcare. And we will soon welcome a panel up on stage who will I would say that they together do have the power to change the world, at least parts of it. But first, we would like to welcome on stage our keynote speaker, Anders Ekholm, who is Director of Analytics at the Swedish Health and Social Care Inspectorate. Herregud. Yes.
Like Emirates, but smaller.
Good.
And not as rich.
Yes. Anyhow, you are warmly welcome, and we are so much looking forward to your keynote presentation.
Thank you. Thank you for having me. It's a pleasure being here. My name is Anders Ekholm. I'm a senior advisor at the Institute for Future Studies, but also the Director of Analytics at the Inspectorate for Health and Social Care in Sweden. I'm going to talk about empathy and high-tech, because we need both things, but not at the same time maybe. But we can use also technology to get more empathy, and we'll get back to that. We know today that society as a whole is a complex adaptive system, and also healthcare is a complex adaptive system. And being such, we cannot do predictions about the future, about societies and so forth. But we do know quite much about what driving forces that are going to shape our society. And it's demography, it's values, and it's also, of course, technology and knowledge. And if we start with demography, Sweden has the longest population records in the world, and it started already 1751. And if you see here, you see the death of people in various ages, and you see the infant mortality rates were horrific, of course, and there was popular to die up to the age of 10. But if you have lived to 10, then the normal death ages was around 60 or 70. So people were old even back then. In the decades that follows here, nothing much happens until the industrialization around 1880 or something. Then things start rapidly to decrease. You see the infant mortality decreases, and the lifespan is prolonging, and in the future the lifespan will be even more prolonged thanks to medical technology. And in 100 years approximately, we will live sufficiently longer time. This is Statistics Sweden's forecast for longevity in Sweden, and the only thing we know about these projections is that they are always wrong. they are always underestimating how long we will live. So we will probably live even longer than this. Some people speak about, luring death, and there are some well-funded startups that are thinking about regenerative medicine and so forth. And basically, we share the same context in most rich countries anyway. Age dependency ratios, that means that the population that works are basically the same, and they are the ones that pays taxes and so forth and transfers the money to the healthcare sector, regardless how we do it, by insurance or by taxes or whatever. And the need, because of the elderly population, will be more. But even if we had more money, we will still suffer from staff shortage. So we can't find the staff. Even if we have the money to hire people, then there's a global shortage of medical trained people. We also have a value change, more individualistic, more personalized, more to co-production. We want to participate in our own care, and of course the rapid technological change. Everyone is struggling with this in the healthcare sector, and we are speaking about organizations, reimbursement system, building houses and so forth. But we still have basically the same outcomes. But why is it then so hard to improve healthcare? I think one thing is that we fail to acknowledge that all care is produced in the encounter between patient and the system and the professions. So regardless how we organize ourselves, it's always this meeting between staff and patient that actually produces healthcare. And if we do reforms, we do reorganizations and so forth, and that doesn't change the meeting, then you won't change the results either. The other thing is that healthcare and our bodies and society as a whole is a complex adaptive system. And if we look at Stacy's matrix model here, you can see here if technology, if you are close to certainty, we really know what happens if we apply this technology, or we don't know what happens if we apply this technology. And being pharmaceuticals, for instance, if we have one medicine and a clear cut of a diagnosis, then we know it will work. And then you have probabilities and so forth. But then if you have 12 pharmaceuticals, do you know what happens here? No, you don't. What happens if you take away number 7? Well, the patient probably gets better, but we don't know. We have to experiment. So we don't know. So technology here. And also agreement in the society or in the organization. If we are all agreeing on what to do and we know exactly what the technology will do for us, then it's quite easy to do things. We can do it the traditional waterfall method. But if we are not agreeing upon what we should do and the technology is not deterministic, then it gets more and more complicated, and then it goes to complex, and in the worst case, it will be chaos. So the pandemic, for instance, is a complex phenomenon. It's a network phenomena. So when it started, it was a lot of chaos. We didn't know what to do and so forth. And then we learned a little bit, and then we go down here, down this stair, and we are not coming down here unless it's about vaccination or PCR testing and so forth, or hand hygiene. It's a simple thing, but to get people to do their hand washing, that's more complicated or even complex. So what we can do to travel down this lane, this coming closer to Origo here, is to have very fast feedback loop on real-time data. That's the only way to deal with complex systems. And today, I think we are living in the complicated society, so we can manage a lot of things in society quite well, actually. But complex matters like climate change or healthcare well-being or public health and so forth, they cannot be handled with the same type of methods that we have handled the societal challenges so far in the 20th century. So we have to do it differently, helt enkelt. Healthcare in the 2020s then, well, it's three things that's basically totally different from the 20th century. And that's the geographical monopoly is challenged by internet medicine and freedom of choice, and also by internet you can also choose internationally, of course. The monopoly of knowledge is also challenged. Before it was only people staying in primary care facilities or hospitals that knew everything, but now we see that the patients are maybe even better than the healthcare professionals. If you have a rare disease, for instance, it's the normality. And of course, AI and different algorithmic approaches and internet. Googling on your symptoms is roughly the same results in symptom or diagnosis precision as going to the primary care center. So it's not that bad with this thing, but it's also breaking the monopoly, but also the supplier monopoly. More players are getting into healthcare. Google, Apple, Facebook, and so forth, they have declared that during the 2020s, they will really focus on healthcare, but also diagnostics companies and so forth, and home labs that you can do a lot of tests at home. I mean, COVID home tests, for instance, for a recent example, or blood glucose meters for diabetics is a long time example where you do your own care, and more diagnoses will be managed that way. And the next level, I think, that's the biological society. That means that we can handle our biology. We understand our biology, and the rapid development of vaccines, for instance, during this pandemic is an example of that we now understand things far better than we did before. So during the 19th century, basically we tried on various cells in vitro, and then what was seemed to work, then we took to mouse models and so forth and so forth. But now we actually can come to this with designer drugs, which maybe these vaccines might see. So, and in the intersection here of technology and also the personalized values, there you have the precision medicine or even precision healthcare. Precision medicine is, well, taken to DNA testing and stuff like that. But we are also looking at precision healthcare, that we can have the treatment chain and so forth working in a good way. And we have these new methods to handle complexity. Former complex civilization, they have collapsed, like the Roman Empire and so forth. And the theories is that when empires evolve and get even more complex, they get too complex and then they collapse. It took 700 years, so it's not a rapid step here. But nowadays we have these new technologies to handle complexity. But we have to redesign our institutions and our way of thinking. And how can we do this? I borrowed a manifesto from Internet, which is an internet psychiatrist or psychology firm in Sweden. And they say that everything that can be done by machines shall be done by machines. Everything that can be done or decided by consumers, patients, must be made, decided by them. Everything that can be done easily, effectively, and fun is to be made so, but we don't want a totally technocratic system. We also need empathy, and they also say that you and I would like to be patients there, and you and I would like to work there. So, in order to have time for more empathy, we have to use technology to free up staff for this. Thank you.
Thank you so much, Anders. You will stay here in the panel, so please take a seat. And I would like to welcome our other panelists as well. I will welcome Jenny Nordborg, who is National Coordinator for Life Sciences, Head of the Office for Life Sciences at the government in Sweden. His Excellency Dr. Hamed Al-Hassemi, who is Head of Digital Health Officers at Department of Health Abu Dhabi. Welcome. Also Niklas Forsling, who is Project Manager for Center for Rural Medicine in Västerbotten, Sweden, please. And Anders, you are already presented. Please take a seat. So we will for the coming hour and a half, actually, talk about the future, but not just with you. We will have different inspirational speakers as well to introduce different subjects for us. But we will go through precision medicine, we'll go through digitalization and partnerships. But just to kick off, I would like to ask you, because the title for this session is Co-Creating Health and Care 2030. So what is your vision for healthcare in 2030? Maybe we could start with His Excellency, sorry.
Hamid?
Yes.
Yes. So I think, first of all, thank you for giving this opportunity to participate in this session. I will zoom in into an area of focus for us, which we benefited during the COVID, which is the digital health, and most particular is about the use of data. Which we have learned during the COVID, the power of the data when it's used and adding value to the patient, you getting closer to the patient, leading you to the precision medicine, as well as the opening up different kind of collaboration when it comes to the use of the data. In our life, we already using data in different forms, but I think when it comes to the healthcare, it's about how we focus on specific use cases that will add value to the patient and to the providers, to the payer, or to the different constituents. And for Abu Dhabi and Department of Health, we invested a lot in the infrastructure in terms of having the data platform that we connect almost all licensed facilities and pharmacies. And we start already using it in terms of applying it on the response of the COVID, and we've seen the power of it. Now, what we're looking for is about how to extend this experience and opening up in terms of getting it into the use of the data for beyond the COVID. For example, on the use of the data, some things related to the COVID, we started the program which is the long COVID. So we're trying to get closer to understand the impact of COVID on the patient, but then that will take us also into other areas of interest. So with the data, we are able to understand much more about the health of the patient as well as the community, maybe the element of their behavior as well. So it's all about data and how we make a better use of the data.
Thank you. And Jenny Nordborg, what's your vision for healthcare 2030?
Well, it strikes me how alike that we are within this area. My vision for the quite near future is also, and my hope is that we will really utilize the learnings that we have from the pandemic in order to be more data-driven, not just talk data-driven, as Anders has pointed out. So I'm heading the Office for Life Sciences within the government offices. That's an innovation itself, to work within government cross-ministry. And I think that we have to also challenge and build on the way that we're working. We have a targeted life sciences strategy in Sweden. We are a leading life science nation with industry in pharmaceuticals, in medtech, in biotech, and also in the new health tech sector. They're absolutely leading. But in order to stay ahead in the future, we also need to collaborate in new ways. And as you said, pointed out so well, to include the patient, not only for the patient, but also with the patient to drive the strategy forward. And I think that is, so the vision for the future is really to actually be able to invest more in prevention, to be able to do so to gain more, to be able to utilize precision medicine in order to do so, and to be sustainable in finding both new business models, new ways of treatments. So it's a lot of talk, but it needs a lot of doing.
Mm. At least a clear vision. And Niklas Forsling, how's your vision for the healthcare 2030?
Yeah, well, I'm coming from another perspective here. I'm coming from a very remote and rural perspective, and use that as a lens, coming from a very small healthcare district, and we're studying similar districts across the Nordics. Our healthcare local healthcare area consists of 7 municipalities. with approximately 45,000 people. Approximately 1 person per square kilometer is living there. So of course, what I really would like to see is that we can stay and continue to develop and increase accessibility of healthcare and care. And of course, we can't do that with the type of service model that we apply today. We need this data-driven approach, but we also need to understand that healthcare doesn't need to be, provided physically in all ways. It could be at distance, and that we also train people and professionals to utilize the distance planning solutions that exist already and make them available for the population. Because my understanding of the population when we speak to them is that they want to make use of these services, but are they available? No. Are the equipment existing? Yes. So what is the missing link here? We need to look into what the missing link here is. This is not only about Sweden. This is all about the Nordics. It's all about, many parts of the world are in the same position. That we have some common challenges to understand what are these system structures that we need to get in place to actually realize this. And the vision is, of course, increase healthcare and care for all citizens across.
And that leads me to the second question I have for you that you can answer directly, even if we haven't had the first question to understand. But what is that missing link?
Well, the missing link is not really understood. Of course, I spoke to AstraZeneca here before, and they said that people are not well trained to actually take care of themselves. And some are saying that the professionals need training. So there are two components, but maybe we need some investment support. Maybe we need some networking, formal, informal networks. Maybe we need to understand that this is about leadership. Leadership pointing with a clear hand, saying that service is for all. We're living in an area where we're having 7 municipalities, of which maybe 3-4 of them may go bankrupt in a few years unless we are changing the service models and the provision of healthcare and care. Maybe we need to integrate healthcare and care. Why not? It's nurses at both organizations. They have the same training, the same background. We all do it for the same purpose. So, we need to recognize that people working within healthcare, they see this as well. They see that how much they struggle to actually perform the services, especially now during these pandemic times. But how could we actually make this more efficient to get more empathy into the healthcare? And we need to make sure that people can take care of themselves are being able to do that. And you will see that people with especially chronic diseases, chronic conditions, they will actually grasp this opportunity, improve their own health conditions by creating insight to themselves. And by that, they will invest in preventive care. Preventive care doesn't have to necessarily be a public investment being made. We are investing a lot of funds in preventive measures. So I think we need to take it careful and we need to be clear here. One thing, I've worked at a bank, and this is looking out at the room, so some of you recognize this. Before, when working at the bank, people came to the office wanted to put in some cash, withdraw some cash, or whatever they wanted to do. Today we use internet banking, and I've worked in the period when we transformed banks from, to go to online banking. What did we do with people coming in? We set them down, opened their internet bank, and they did their own bank, whatever they wanted to do at their bank services. And after 6 months, we trained them so they are not coming back to the bank. If you say to people that I need to go to the bank today, people are actually thinking that either you're getting divorced or that you're buying an apartment. So that's how it is. And it will be the same with healthcare. Healthcare should be there, it should be accessible, and it should be physical when it's needed. And they should be able working within healthcare to provide empathy for their customers or clients or patients, whatever we call it. But we need to free up the space for that to happen.
So, Anders Ekholm, this sounds quite aligned with your vision that you presented to begin with here. But how would you describe the obstacles to reach this vision?
First, I would rethink the vision a little bit. We are always talking about the healthcare production perspective. So as a patient, I would like to have a healthcare that is together with other social organizations are thinking and supporting me in my health. And as a taxpayer, I would like it to be as efficient as possible. But I think it's a lot of obstacles. A few I mentioned. One is that the complex systems. So it's hard. It's really hard to reinvent complex systems because they tend to evolve during the time. So you have to be fast, and we are not that fast. The most countries are rather slow in taking new initiatives and so forth. So the key thing here is learning that the system is always learning from real-time data on a daily basis, and that you have actionable data in this, and also that the system is able to implement new innovation and experiment with them, because we need a lot of experimentation because we don't know how the new healthcare will look like. So experiments and continuous learning, I would say, is the answers, and the obstacles are path dependency. That is, organizations tend to do what they did yesterday. Me as a person, I tend to do what I did yesterday, and so forth. We are locked in our habits. So on a personal basis, I'm locked in my habit, but also on an organizational basis. So building organizations from bottom up new, that's a huge opportunity to do it on a good way from the start. So you don't have to need to do the same mistakes as the old systems has done.
His Excellency Hamid, do you see the same kind of obstacles when you try to implement your digitalization?
Yeah, but I think we'll go back to the first question in terms of the vision as well. It's very difficult to have a single vision about where we're heading, and I think we are much more open in terms of understanding that there is element of uncertainties about how the use of the data and digital health will evolve over time. So the way I look at it, that we'll have different pathways, different technologies, different areas of focus that will transform the healthcare. And the way I look at it is, if we look at the solutions, very simply, I mean the solutions and technology that have high rate of innovation, but as well as what is important also, high rate of integration to the model of care. So it becomes more usable, it much more that we can see the benefit of it. Now, when it comes to the challenges or the missing links, in the healthcare, we have been focusing on the clinical data, and this is what we have been doing for a while, which is very useful. I mean, we have a great benefit from using it, so we understand the different outcomes, the chronic diseases that evolving. But I think one element which is missing, at least for our case, and we want to close this gap, is how to complement the clinical data with other data asset, like the social determinant, or so if you're stepping into a physician will not look at only at your clinical record, but then with the use of the data, if we are able to bring insight about is this person active, the nature of activities, the nutrition, so other aspect which is maybe the physicians that are blinded, they're not knowing, so that maybe the treatment or the care pathway could be done differently if we were to know much more about holistic view about that individual beyond the clinical element. And for us in Abu Dhabi, we're focusing in this area. So we're completing our clinical platform and the data platform, but now we're looking at what could be the other use cases that we can utilize, where we can bring different data elements, which is the social determinant or other factors, which I think will be add much more better outcomes, and the experience of care will be much better. So this is one of the key areas. The other missing link, technology is evolving, the healthcare is evolving, but then the financial model is not really evolving with the our aspiration, how we want to move forward. So we have to, in a way, to rethink about the financial model so that we encourage the different actors within the system to adopt new technology, introduce new technologies, and offering it for their patient. So I will just focus into this area. Certainly, there are some other missing links. Nothing is perfect, and I think it's only the start of the journey of digital health transformation.
Sure. It sounds quite familiar, your description here. So we will get back a bit to digitalization later, but we will shift focus a bit and talk more about precision medicine. Technologies enabling precision medicine can be truly transformative, as you were talking about also, Anders Ekholm, in the beginning here. Patients can be correctly diagnosed much faster, and treatments can be tailored after individual and so. And we will discuss the implications of this. But first, I would like to welcome Andrea Balage, who is Vice President Sales and Marketing at Olink Proteomics, which is one of Sweden's most successful companies within precision medicine. And you will showcase a bit what possibilities there are. There you have the clicker.
Thank you. Yeah, so thank you very much. We talk a lot today, and we will talk much more about precision medicine. But I would like to bring your attention to a couple of facts, how imprecise the medicine that we're practicing today actually is. Only 1 in 5 patients respond to the top 10 prescribed drugs today. I think it's a very shocking statement, but it is the truth. And this is because how we set up clinical trials, drug approvals, and so on, and what tools doctors and physicians have in their hands to understand their patients. The total cost of drug development, which is already very high, constantly growing. Although the drug industry did magic in the pandemics with vaccine development, our traditional drug development is still pretty slow, lengthy process, very expensive, with increasing cost. And furthermore, it's not very efficient. Very few of the drug compounds or drug candidates that goes into this expensive development process makes it to the final stage and will really benefit patients. So why is that? Actually, I would state, talking to a lot of very successful scientists, clinicians, drug developers in the world, we simply don't know enough about human biology. The picture of human biology is blurry, and we need to know more in order to be able to practice precision medicine. Genomics, the most known so-called omics, the last 20-25 years generated tremendous amount of data and information and gave us hope that we will understand human biology and we will be able to practice precision medicine. But now we all know it's not true, we need more. So we strongly believe at Olink that the next century's healthcare will be based on data from multi-omics. Among these omics, I would say that proteomics, the study of the proteins, the molecules that build our body, makes us function, and which transition from health to disease, and which drugs targeting are probably one of the most important or the most important omics. So we need to study our proteins in the human body. So for that reason, we at Olink developed innovative technologies and innovative tools to first time in history be able to study thousands of proteins in tiny little amount of biological material in order to much better understand how our body is built, how it works, what exactly is the transition point between health and disease, and to be able to develop drugs more efficiently and administer them to the patient, the right drug at the right time. with the help of this knowledge that we will generate. So, thank you. That's what my inspiration, hopefully.
Thank you very much. Just please stay here with just one question here. Can you mention some area where these kind of technologies can serve medical needs today that are unmet today?
Yeah, one of the most recent examples. So, as you know, when COVID started, but we realized that some patients hardly had any symptoms, some had very light symptoms, and some died with seemingly the same conditions. Studying the protein molecules, and actually in the pandemics we run very many COVID studies and COVID-related studies, and by the help of protein molecules, we started to reveal the details and the mechanisms why certain people die, why certain people hardly recognize that they have the infection. Other examples that today we don't understand disease in high resolution enough. Some of you eventually working with cardiovascular disease, heart failure patients, we call heart failure. Studying protein molecules of heart failure patients, we realize that there are at least 5, 6 completely different mechanisms that can lead to heart failure. And those different mechanisms, of course, require completely different treatment. With help of these protein molecules, we can identify which patient requires which treatment.
Thank you. Very good example. Thank you so much for this, Andrea Bloghi. And while you leave the stage, I would like to welcome Her Excellency Mariam Mattar, who will join us here at the panel.
Thank you.
Please, and welcome.
Thank you very much.
And very timely for the precision medicine discussion, right?
Yes.
I will present you in a more correct way as well. Sorry, maybe you should do that by yourself. Let me know.
You will make my life easier.
Yes, exactly. Yes.
So thank you very much for inviting me today and to be part of this prestigious panel. When you talk about precision medicine, maybe you saw me, I was not able to attend earlier when we started the session. Simply, I was in a very lovely discussion where we were discussing the Egyptian genome. And in this Egyptian genome, one of the main elements which we'll be focusing on to identify epigenetic markers for the Egyptian. And that itself reflects directly to why somebody will acquire COVID, while clinically he will be completely different, not only from his sibling, even from his identical twins. Mm-hmm. And that itself an eye-opener. And allow me to go back to my lovely country. Welcome everybody to United Arab Emirates and welcome to EXPO. So in United Arab Emirates, we'll not talk about future right now. Let me share with you some of realistic experience, a very humble experience which we developed in the past 7 years when it's come to epigenetics and genetics. I am a physician, specializing in community medicine, but again, I went back to the school chair where I did my molecular biology in genetics, specifically in common genetic disorder in my lovely country. So during those past 6 years, we sat in a very focused approach on a specific target audience in my community, specifically for something called familial hypercholesteremia, where a specific target tribe in my community, they will acquire high level of cholesterol. Whatever medication you will provide these people, they will, unfortunately, will not respond well. At the same time, they might have some impairment in their liver function. So you had to stop the medication. By going back to their genetic to identify what's the difference, are we different than any other individual who's sharing us the same environment? We came to know that we have 4 common genetic mutation, which is very specific to our ethnicity in this part of the world. And those people who acquire this type of mutation, simply as a physician, I am not allowed to prescribe any medication which usually work on cholesterol, especially there is some tablet where he need to take it at night. So only by having this understanding and know that this individual, he doesn't have the receptor for that medication. So we stopped giving him the medication. And at the same time, we were able to identify what is the environmental factor which will switch on some of those markers which help his body to take again those cholesterol within the cell. Simply, it was high fiber diet, nothing else. So we made sure this individual, he will have 6 grams of fiber 3 times per day, and within 6 to 8 weeks, magic, his cholesterol coming down. And he is continuing in a very healthy lifestyle and without single medication. But here I need to add a sentence with 100 red line underneath. Again, the physician, he is the one who will decide if this patient should take this medication or not. Because in particular stage, even if you have this type of mutation, you still will need some help of that medication to drop it in an extent where he will tell yes or not. So this is a very simple example, a realistic example about my lovely small country, very young, only 50 years old country. But I think we talk about presence, and with exchanging the experience with people from Sweden, that itself will help us to build something very strong and progress faster, inshallah. We might be maybe come up with some intervention before you in Sweden. You never know.
And what you just told, very interesting examples you just bring us here. But that makes me think that we were talking about more holistic, when you talked about your vision earlier for healthcare 2030, was a more holistic. And sometimes when you talk about precision medicine, you get the feeling that it's a very not so holistic. It's very specialized and very focused on details. But this, your example here with the fiber, at least in my mind, makes me think that we are heading to a more holistic view of the body. How do you think about that? Is that Anders Egon?
Yes, definitely. I mean, precision or personalized medicine is going to the personal. I mean, you have to look at the habits, your exercise habits, your food habits, your drug habits, and so forth, and everything. And are you lucky? And how do you become lucky? Well,
very true.
by meeting people that is nice to you and don't upset you. So you have to think about the whole life when you prescribe drugs, basically. So I think the personalized medicine is going back. It's more technological, but it's less technocratic in the best sense, if we can get there anyway.
Mm. And Jenny Nordborg, I know that precision medicine is one of the top priorities for the Life Science Office in Sweden. How do you respond to this invitation from UAE here?
Precision medicine is really a cornerstone of the life sciences strategy, and I think that this is a fantastic example, very important also for policy development, because we often see precision medicine as extremely advanced and very hard to understand, also for policymakers in that sense. And I think that this is a very important example, so you make it understandable for everybody. You don't have to know how to make genetic tests, so you don't have to understand epigenetics, but you do understand that food affects you and how you live. And I think that that is a fantastic example. But I also want to tie to what Dr. Balaga was saying from the OLIC perspective, that precision medicine is about all the omics. It's, of course, we start and we often talk about the genetics because that's where we come quite far, but it's also important to include all the other omics, from imaging diagnostics. Medicine is not pharmaceuticals. Medicine is also imaging or both diagnostics and treatments in that sense. And we're trying to work with precision medicine in such an holistic way, but I get very inspired by utilizing your type of examples to make it tangible and understandable for everybody, because that's when it's also understandable in a policy perspective. So I'm sure that your innovations and our innovations will have a lot of joint co-creation in that sense.
And Dr. Niklas Forsling, yes, when you meet patients, where do you think this comes in the meeting with the patients?
I should say I'm not a doctor, so.
Sorry.
But we work with development of of health and care for the remote and rural areas, and I think, as you're saying and as you're explaining it, I mean, a holistic view from a remote rural perspective is very important, because we view that we need to develop the solutions from our point of view with our lens on, because then we get tailored solution for our population, which is what you are saying with precision medicine and also the biomarkers that you spoke about from Molenk and what you explained here. So I think that we could actually get better services and better targeted services for the population in our regions as well. And this is very, very important, because even though that I say that we are a very, very few number of people, I would say in the case of the Nordics, half of the population are living in remote and rural areas. Only half are in the urban areas, even though the trend is urbanization. But we need to speak about holistically also for the entire population. And precision medicine is such a tool that could actually help that.
Her Excellency Mariam Attar,
Please call me Mariam.
Oh, I will do that.
Yeah.
I will do that.
Yes.
Mariam, how do you think that this is it easier to encourage patients to follow drug prescriptions and so with the precision medicine diagnosing them?
I don't want to say things. People, they always tell me, Mariam, you are very optimistic. But again, I'll give you another example from my lovely country, answering your question. It goes back to 2005, 2004 exactly, when we thought that we need to empower the community about the knowledge about how essential it is to be screened before getting married for some common genetic disorders. And I started the journey back when I graduated from medical college in 2000. So where I had the chance during my internship to go through a specific center where they treat something called thalassemia, which is one of a very common genetic disorder in my country at that time. So when I saw how the children are suffering, I was wondering, is there any other solution than waiting for them to come and be treated? I came to know that in Cyprus and Sardinia, they were celebrating 11 years where no single child born with these disorders. So I knew that they don't have a magic stick. Simply they had a law and they had enforcement. People are aware, everybody's screened. The church will not approve the marriage if they are carrier of a disease, and so on. So it was my mission in life. And I'm coming from a very humble family. My father is a taxi driver, so I'm not coming from a rich family, from a big tribe, but I have a good wealth of values and knowledge. I was the first on the medical college on my batch, so I have a heavy weapon with me, to go ahead. So I started the higher journey. Everybody told me, Mariam, it's very difficult. The tribe leader, they will not agree to screen their daughters. Imagine that 2001. In 2006, in March, I was the guest of honor in the cabinet where a law was declared by the prime minister, but nobody will get married in my country unless they are screened for sexually transmitted disease and for common genetic disorders. And this law, by the way, didn't come from up to down. It was the other way around. I empowered the community. I started with a lovely group of volunteers from 17 nationalities. They are better than me in experience-wise, knowledge-wise, and they came on board. We empowered the community. We told them why we need to do that. You cannot imagine, within less than 3 months, we got a signature of 10,000 students above 18 that they are willing for this law to be obligatory in my country. So that itself will tell you, if you know how to speak with your people, if you know to use the tool which they can understand to tell them why you need to do this, they will come on board immediately. And the same is applied on whatever we would like to enforce the community with good tools which improve the quality of their health. So in my opinion, this is an answer for you from my lovely country, from a very young country like United Arab Emirates.
And it's obvious that you're all representing areas where this is a priority. But as you were also pointing out, this is a huge opportunity, of course, for global health. How to make sure that the possibilities with precision medicine will be spread around the world and even to other areas where this is not a priority?
Yes, because what you lovely story. What I hear you saying is that how you actually helped through dialogue with the population in your local community, actually created trust. Mm-hmm. And as we say in the Nordic cooperation, what is different a little bit between the Nordic countries and the rest of the world is trust. That trust is the Nordic goal, but now it happens that you also have trust in your community, and by that you could actually do policy development. And I think this is a key point if we are going to speak about precision medicine. People are sitting here, maybe in this entire room, feel safe about this. But how do we get the population to become part of this? Because this is a movement. We need to take a step back and be more holistic and still believe that we are going to be getting better treatment. And we need to, building the trust and speak to the population and speak with the population on their terms and conditions. And this is not easy. And we're thinking about some simple things in healthcare that simply doesn't exist. And here we're speaking about precision medicine that are much more advanced, how to do the communication. So I think this is a very, very important factor, and you outlined it very well, and it's simply about communicating it to the population's own language and the way that they speak, and they will follow you, they trust you.
Allow me, can I add a point when it's come to the trust? Sorry. When you ask me a question about my country, I cannot stop not talking. I believe it's not fair, again, to generalize the experience and the response of the community, which we have in the United Arab Emirates, to the rest of the region. And that's, again, it's not an opinion. It was a discussion brought up before COVID in one of GCC country, where they wanted to have the same approach which we had in the country, but they were not successful. Again, I believe what makes us in United Arab Emirates very unique when it's come to implementing applied science to the community, that I believe it's our leader. The region lacks such type of a leader. And I'm not promoting our leaders, but again, I goes back to another story from my personal experience when it comes to trust. It goes back in 2000. I like number. I love numbers so much. It goes back to 2008, where I was in charge of Dubai Strategic Plan for Health, Education, and National Identity. At that time, we had a discussion with the very senior people, knowledge-wise, experience-wise. And they were in debate with me, being young, short, and so on. And they are all older than me. And it's so nice to be pretty and young among other ladies and gentlemen. Anyway, I used to use that. It gave me huge power, wallah, to stay throughout the day. Sorry, go back to this. So we had that discussion. It will never end by accepting my opinion or discussion. Imagine, we had one meeting with His Highness Sheikh Mohammed. When I supposed to give the presentation, I opened the PowerPoint and I start talking about it. Can you imagine, within the third slide, His Highness stopped me. He said, Maryam, can you tell me more about 80% of the population? I said, Your Highness, it will be in some other slides. He said, Maryam, now for the past 7 minutes, you are talking about Emiratis, how you empower them, how you will maintain a strong safety net to them. But what about the 80% of the population who are non-Emirati, and they chose Dubai to be their second country? and I don't want them to have a second thought about it. Can you imagine? We stopped the meeting. We went back and we did it the way I wanted from the beginning, you know? So imagine when you have such type of a leader who you and him on the same wave, and he empower you with that. So we went back and we changed the whole strategy where we make sure everybody within the center, the citizen, the resident, and that's what makes our country unique. With one meeting with His Highness telling him why you need to do this, you will not wait for the parliament to approve it, you know? And you will not wait for a budget to be approved from wherever. Khalas, you get yes, done, budget will come, will follow. And that's what makes our country different, by the way.
Fantastic. So again, I guess we are there that all levels must align.
Yes.
That's we had the same in the morning when discussing the antibiotic resistance. How well is Sweden aligned when it comes to decisions like this? Whoops. Jenny.
Yes, of course. I mean, what we have talked about, Sweden is has a trust-based alignment. So as we know, and that it's the regions who have the mandate of the healthcare. It's the government has the mandate of the agencies and of the universities. But it's the importance is really from the trust base from the peoples and the professions. And I want to bring something else to the table, which really challenges everything when we talk about precision medicine, but because it's all good and we all know that, but precision medicine is also about getting fantastic new enables fantastic new treatments in advanced therapies with new gene and cell therapies that is already today revolutionizing our whole healthcare sector. Now the challenge for Sweden, for the Emirates, for any country is, as you brought up in the beginning, also the funding and reimbursement models to be able to do so. Because for Sweden, it's of course, since we are trust-based in our organization, it's key that we maintain this trust, and that's built on equality, on sort of both being able to get the treatments that are available, but also to have sort of an equal balance in that. And I think that is a key challenge, and of course it's not a key challenge for Sweden, it's for any country. And I think that the way that we can work together between both the industry part and the policy part and the academic part, also on implementation and finding new models, I think that is going to be an important race for the future, for a system like Sweden, which is more slow movement, but quite strong while moving.
It's nice to be different, you know?
It is. I mean, that's co-creation.
Yes. I always believe different is richness.
Yes.
Can you imagine if we are all alike? It will be so boring, you know?
Anders Jacob, you were
Definitely, yes.
waving for a while here.
Well, in Sweden, I think the specialists in the clinicians, they are really keen to adopt the new technology, especially in the big university hospitals. I don't think we have to wait for those to use this new technology. I think the more problematic thing is regulations, for instance, that we have old regulations that might put a stop, an end, or make it more difficult. Regulations around data, when we're talking about the holistic approach, then we have some data regulations that might not be very good for this development. But the other thing is also scientific, because we have to get used to the old traditional medical trials systems with mean values on a population average and so forth. Okay, you're a white middle-aged man, you should be treated like this. If that's not longer true, then we have to need to think about new ways of actually saying that this treatment that is specialized only for Jenny, it is actually the best treatment. And why isn't this mix of treatments the best for Jenny? So, and how do we do that? In traditional scientific science, we say that, well, on average, this is better than that, and so forth, in the old non-precision medicine. So I think it's more a science question, and how do we talk about precision as the better precision or the worse precision if we lose averages and p-values and the stuff that we usually talk about in science.
What should we rely on instead?
I think we have to do more of outcome measures. So does it really work for this person? And actually,
on an individual level, that is.
On the individual level, yes. And that's how traditional medicine also, works. Because if you're going to the elderly care, in average, they have 12 pharmaceuticals, and you don't know actually how they interact with each other. Then you have to try. You have to experiment to take away another, or you change that one, and so forth. And wow, now you're not dizzy, and it looks good. So basically, we are already doing this experiment, but we are not following it up in a structured way so that we could learn from it. But that's more, crucial.
So the whole thing with big clinical trials is just us fooling ourselves, right?
Yeah. So and actually, it's now. There's in the Swedish authority that approves pharmaceuticals. They now get applications from companies that only do phase 1 studies, because all the patients are already patients. The phase 1 is actually live on real patients with the
the phases are becoming harder and harder to define.
Blurred, yes.
By experience. Mariam, please.
Yes. Can I add again another story from my
Absolutely.
country? When we started here something in Dubai called Dubai-Tech. It is a city where pharmaceutical company, anything related to biology, they are allowed to come and work as a free zone. So we had Pfizer, we had Novartis, many well-known pharmaceutical company, they came on board. And that goes back to 2011. So where we had a very healthy discussion. And being a physician, I always used to wonder why there is no prescription where they say this dose is this much for women and this much for men. Why there is no definition? And we know biologically we are completely different. We have 5 days per month where we suffer under estrogen, and still I need to maintain the same dose which my husband is taking. And again, I have this personality. If something goes in my mind, I like to talk about it loudly. So it was a discussion where I had some authority in that discussion, being under secretary and so on. I said, okay, is there any trial or guidelines where we specify male and female? They said, no, this is not related. It's not in the international guidelines. I said, okay, can we have our own guidelines? They said, no, Miriam, it's not possible. We passed that away. Then we had a very high-level discussion where one of high authority in UAE was attending. Then I raised this point. I said, okay, we are giving license to these companies through this free zone. Are we able, at least if they would like to try a new medication or clinical trial in UAE, to come up with this idea where they can differentiate between male and female? They said, we can, but we cannot make it forceful on them. I said, let's start. Can you imagine, in 2011, we had this discussion. I attended 6 pharmaceutical discussion, and in 2016, I was in Riyadh, and they raised this point from the same pharmacy. So the good news that from our small little country, with a very high-level discussion, a thought which came up, and I'm sure there is other scientists around the world, they raise it. But if you have an authority and you follow up an idea, I'm sure it will see a light one day. And that's why very soon you will see that too many clinical trials, which will start in UAE, we'll try to have our own new guidelines. But again, it's not our guidelines, it's some higher discussion which was going on globally, but we would like to take the leadership and to be the pioneer in enforcing those requirements in some of those clinical trials which will go on in United Arab Emirates. I think maybe this is not a traditional approach, but we believe it works somehow in our lovely country.
Sure, and great example, and I think we will switch to back to digitalization actually, and listen to a little bit more to Niklas Forsning about the northern Sweden perspective and your project there for Center for Rural Medicine. Because I mean, sometimes when we talk about digitalization of health, it's like something cool and nice add-on, more or less. But for you, it's sometimes the one thing needed to be able to make access to healthcare at all. Please tell us a little bit about.
Yeah, I mean, exactly as you're saying. I mean, if we speak about healthcare and care through distance planning solutions, this is nothing new to us. We've done that for 25 years. So from our small primary care center, we call it a cottage hospital because we have some beds at the cottage. We're like more of a small hospital. We have had some equipment available for doctors to speak to specialist care that are then the University Hospital in Umeå, Norrlands universitetssjukhus. And in that context, this has not been anything strange for us. I mean, to some extent, it has been a matter of life and death sometimes. We're using doctors on call for all the different healthcare centers, primary care centers in these 7 municipalities. So we have one doctor, and the highest profession that are in some of the primary care centers are a nurse. And they call to the doctor to get medical advice and make the decisions and calls about the patients coming in at night. Why do we do this? Well, of course, it's a matter of resources and people available. So we need to provide the best possible healthcare for our population. That's what we need to do. So we're looking where the doctors are and see under which conditions do you need to function, to operate within, to work with us. And for instance, we have something called Västerbotten Without Borders, which is then us looking into the opportunity of providing different healthcare services across country borders. So we have doctors from Malaga working for some of the primary care centers in Västerbotten, in our region, because we have access to doctors in Malaga. And they are excellent. They don't get all the patients, but they get many of the patients, because some of the cases are more suitable for doctors at distance. We try to integrate healthcare and care. So when doctors are making visits to patients at more, elderly care centers, which we do in Sweden, together with the municipal nurse, the doctor is at an iPad. So we have one doctor that are serving currently 4 municipalities, doing 350 visits per week online. Of course, this is very efficient, but the most important part is that each patient gets more time with the doctor, and they get the same doctor every visit. They don't have to tell their story over and over again. Yes. And what do you prefer? If you get to choose, do you want a new doctor every time and you don't know who you meet when you come to the primary care center, or do you want to meet the same person? Sometimes you meet the person physically, sometimes online. So this is a matter of accepting service models that are available for us and are within our reach. We have seen this in the Nordics. We have studied the Nordics. We have actually mapped out all the distance planning solutions existing, services existing in the Nordics, all of them. They are not advanced. I mean, you're most likely far away, far ahead of us. But anyway, the interesting part of this is that we see a clear trend that healthcare regions, healthcare areas that are more advanced in digitalization, they go towards integrated healthcare and care. And this is being done in remote and rural areas where the number of hands, the number of professionals are less available because they have to. I don't think that they get... We don't know the quality of care, but the continuity of care become stronger. And normally that's an indicator for higher quality of care. So, it's very difficult to make these randomized studies on who wants to meet a doctor today and who doesn't. So it's accessibility, period. So
for you, the driving force has been to enable care that hasn't been able to give previously. Dr. Ahmed, what's the driving force for your digitalization?
Yeah, I mean, I touched a little bit on initially about the digitalization and more focusing on the data, the use of the data. In Abu Dhabi, I mean, Mariam already mentioned, we have, and UAE in general, we have done great kind of initiative, different building blocks when it comes to the genomics. We launched our national genomic program. We established in Abu Dhabi the Center for Research and Innovation, which will focus on genomics and other areas. We invested a lot in terms of the building the data platform, and we enabled the clinical research, clinical trials, and the essence of it is about building the right capabilities within the country and in different areas, so that we are able in terms of getting into the frontier of the new technologies and using it within the healthcare. For example, we're working now with different partners, and the essence of us, how we are working, and maybe this is related to this event, is about how we collaborate and co-design, co-create the different pathways for the future of care. So we are working with different partners, different pharmaceutical companies, G42 and other local firms, building this data platform so that different actors will be able to consume and deal with this data, and hence also we created the Health Tech Hub, the startup. So we want having the right capabilities, the right infrastructure, but also we want to mobilize the different actors within the system to contribute to the growth of the healthcare. And we were the first in terms of doing the clinical trial during the COVID for the Sinopharm, and it was very courageous step to do it. It was not an easy decision, but the country have done it, and we have seen the outcome and the result. And in the future of this kind of work and intervention is building more capabilities, building infrastructures, and more collaborations. We signed different agreements with different pharmaceutical big firms to into different areas, whether clinical trial or real-world evidence or other kind of use cases that will benefit us as a country, but also will benefit the firms globally. We launched the Life Science Park as well. So you see that in Abu Dhabi, UAE, we have different building blocks that are already in place, and eventually we will have the right capabilities, and we will see ourselves pioneers in terms of the research, and not only consuming technology, but also contributing and creation of the technology and different solutions. So we have done a lot, and I think much more is going to come by the different policies that we have enabled. We have seen a lot of international firms from different areas coming and collaborating with us. Last week we participated in the Arab Health. We have demonstrated around 15 different solutions, and all of the solutions around digital is actually done through a collaboration with different actors within the system. And this is the essence of the pathway that we develop. So as you mentioned earlier, it's about how we become agile as well as experimenting different solutions, different digital solutions. Some of it will work, some of it maybe we'll revisit and we'll enhancing it. So becoming more agile, experimenting with different technologies, but the main area for us, as we discussed early on, is about how we have a focus on the outcomes for the patient. So yes, I mean, building capabilities and different building blocks becomes essential for the future of the health in Abu Dhabi and UAE.
All areas kind of connect here with the outcome. One thing that happens with digitalization is that new players come into the field. And I believe that we have with us our next speaker, who is Paul Baratta, who is Segment Development Manager at Axis Communications, right? It's always a little bit exciting. I think they fell asleep inside the technical room. No, they didn't. Yes?
Yes. Yes, on.
Yes. Welcome, Paul Baratta. Please tell us a little bit more about your work in the healthcare field.
No sound.
Here we go
Hi,
again.
good morning from the United States. My name is Paul Baratta. I'm the Healthcare Segment Development Manager for Axis Communications. And what I wanted to share a little bit today is what we're doing with our technology that we have that traditionally you'll see in hospitals that are security, but that how we're taking that technology and using it to improve patient care. And, you know, traditionally, hospitals have a lot of video and audio in their hospitals, and it's, you know, traditional security use is that a security officer will be sitting behind a desk, and there'll be hundreds of cameras in front of them, and it's really more of a reactive response to an event. They respond to an event, they go back and they review the video. What we have found is that by adding a proactive response, by adding analytics at camera edge, bringing those eyes and ears with audio, and also using other partners such as BriefCam, which has actionable intelligence, sound intelligence, which is acoustic monitoring, facial recognition, mass notification alerts from things like links, we're able to bring a more proactive response. So one of the things that I know that you've been talking about over the last couple hours is the epidemic that's happened in the world. And one thing that has been an epidemic in healthcare for a long time has been workplace violence. And it's a global phenomenon. We have, especially in the United States, it's one of the most dangerous jobs in the United States for workplace violence, both physical and verbal abuse that clinicians and staff respond to and are subject to. And we took this technology that every hospital has, and what we did was we talked to our end customers and the people that are in the field and said, how can we help you reduce workplace violence? How can we also help bring better care to patients using what you already have, the investment that you already made in video, audio, and analytics? And how can we reduce workplace violence and keep people safe? But also, like I said before, is improve quality of care to patients. And so what we have developed is solutions that make hospitals smarter by taking the video that is currently available and adding those to clinical applications. An advantage for us is that we have an open infrastructure, so we can integrate with many systems. And one of the things that we have been doing and very successful is we have started doing telesitting and tele-ICU applications through electronic medical record systems, as well as using our video and analytics and our audio to capture data points so that we can help a hospital determine how many people are coming through an area, how long the wait is, if there's a sudden surge into the hospital, how to get more staff to respond to that surge? How can we improve patient experience by bringing more staff to patient registration using our analytics like line queuing and being able to send an alert to send more people into patient registration and then throughput? How can we take what we normally do in traditional security, which is basically keeping people safe and keeping assets protected, and move that into the nursing, IT, and clinical area? How can we take these analytics as well to reduce falls, to maybe work with nursing and others on response? How, if there's patient behavior like aggressiveness, can we use acoustic analytics and be able to alert staff to proactively respond to those events? And then the most important thing is the future. How can we take what we're doing today and build telemedicine solutions with what we have? So again, a smart hospital technology for us is all about video, it's audio, access control, protecting those assets and keeping people safe, and then at-edge analytics. One of the things that people really don't think about when you're talking about video and audio is how can that become the eyes and ears to the clinical staff to be able to see a patient and respond proactively to an event. So many of these devices today are edge devices. They're on your network today, and they're not being used other than to just be a reactive kind of device. What we have been developing is how can we take these devices and make them smart? And a good example is in our audio application. We've worked with Epic, which is a electronic medical record system, and they actually have now a drop-down in their software, a drop-down choices for preferred language through our audio devices. We also use our video in analytics such as sound intelligence to listen for not only aggressive behavior, but coughing, excessive coughing, and also telemetry alarms and physiological alarms, giving those eyes and ears to the clinical staff and how to respond quicker and better. So we really took a real major shift for us in technology, not only from the protection of staff from traditional security, but how can we also reduce the use of things like personal protective equipment? How can we keep staff safer before they enter rooms? And then what's the return on investment that we've made with using this technology? And how can we help doctors and nurses and others really understand the patient or understand what's going on in the hospital proactively? We actually send through our video management platforms this information directly to the staff. They can go to their cell phones, it can come to their homes. We're able to provide telemetry and physiological monitor data as well, and so that they can actually see a patient from any location in the world and be able to provide some advice. So one of the things that we started out doing was we had video in the role of patient watchers. And for us, what a patient watch is when a patient who is maybe a wanderer, maybe a forensic patient or somebody who is a threat to flee, they would place a person one-to-one in a role sitting and watching that patient. Sometimes it would take days that you would have a security officer or a police officer or what we call a patient watch observer sitting in a room watching a patient. And really, you know, you have the human factor where somebody could fall asleep, they're not paying attention, and there were very much so an increase in violence as well, where people were being attacked in those roles. We were able to provide video and audio, and we were able to provide analytics to reduce the amount of patient watch hours, to reduce the amount of people that need to do that, and thus we showed a quick return on investment. The other thing that we use video for is we have artificial intelligence now and deep learning at the edge in our solutions, and we're able to provide artificial analytics in fall detection. we're actually working with a couple AI people today on how can we start to develop develop analytics not only to detect the fall, but pre a fall. Can we start to use AI to alert people before the fall happens? And that's really the golden ring. That's an expense that happens, especially here in the Americas, that has really drains a budget for a hospital, costing millions of dollars a year. So really, the whole idea of now shift the technology was, how do we take what we have today and improve patient quality of care, reduce the use of personal protection equipment, and improve response, not only for security in those people and reduce workplace violence, but how can we improve the response for clinical staff as well, using the technology that's already there. And some of the solutions that we have include wireless carts and wired carts, mobile wall-mounted units, fixed ceiling cameras that are already there, and IV pole mounted as well. One of the things that was very interesting here in the United States is they opened up a lot of different areas like convention centers. And one of the biggest concerns was, how can we communicate to all the patients? We were able to provide IV pole mounted devices, door stations or intercoms in those situations, not only to be able to provide somewhat of a nurse call system where the patient could call and talk to the nurse directly, but we were also able to put analytics at the edge of these cameras so that we could also provide for better care to the patient. So this is just a quick review of what we did. I wanted to just thank everyone for including me in this presentation. And if you have any questions, I'm more than willing to answer them.
Thank you very much, Paul Barata, for showcasing that you clearly you add value to the healthcare system and to the hospital. I just wonder, coming from the security technology sector, did you feel welcome to the healthcare sector, or has it been hard for you to enter this sector?
Well, no, actually, so we've been in this sector for a long time when it comes to traditional security, and we've actually been very well received because we've been able to reduce cost. And I think that's an important thing, especially here in the Americas, is that not only have we been able to reduce cost, but we've been able to increase patient quality of care and actual patient satisfaction. So I think that's been a real win for us. So we have been, we're now covering thousands and thousands of beds. We're doing a lot with children's hospitals as well. We're providing parents who have their children in, say, the NICU, where they're in bassinets for a long period of time, the ability to look in on their child and be able to see them. And so we've really been well received. We're doing hundreds and hundreds of hospitals, thousands and thousands of beds today. And really, it all started out with, traditional security, just keeping staff safe. But we've really morphed into this, and being able to now to provide clinicians with actionable data as well from this video and from these devices has been really important and a real win for us and a win for them.
Okay, thank you so much, Paul Barata, for joining us.
You're welcome. Thank you for having me.
Thank you. And so I will turn to the panel. What other players do you foresee will come into the healthcare sector that we're not used to see here? Anders Ekholm, you are the future-looking person here.
Well, one thing I've seen a few, but just a few examples of is weather data. I just heard from a hospital in Canada, I believe it was, and they sent out warning messages to all the patients with asthma if the climate was colder than minus 15 degrees, because a lot of those patients needed to go to the hospital. So they stayed at home when this happened. So and of course you can think of a lot of climate data being used for for when it's too hot or too cold or too humid or whatever. But so I think this is the thing with digitalization, that we have some data sources that is daily accessible, like these cameras, and we don't think about it as something that we can use for utilizing it in the healthcare sector. But I would say that this is the thing, that when we have digitized, that is, we have translated all our analog data to digital data, then it's very easy to put in other stuff. But if you don't have an open electronic record system, for instance, that can handle data from well, cameras or audio and stuff, then it can't be handled. So I guess this will be some sort of exponential thing when we use, and of course, I mean, data from my watch that knows everything about me, and data from Spotify that knows what I like for music much more. So when maybe I listen to slow music, then that's meaning I'm going to be depressed. When I'm playing less with social media and playing more with games, that's an early indicator of depression, for instance. And the way I walk, so my devices know exactly how I walk, but also how does people walk in a city. That's a good predictor for flu, for instance, or early pandemics and so forth, that you see patterns. And how do people Google, on what words? Then you can see also, and I know the authority is actually using Google Trends to look for, when people look for influenza symptoms, they know, now it's coming, and then a week or two later you can see it in the hospital. So all the data will tell us something about our health, basically.
Again, we are looking at a much more holistic view of health, it seems. It seemed like you wanted to say something. Yes.
So for us, we worked a lot on the digital health, and the theme of what we're working is about how to bring health in a platform. So in a sense, if we are able to have this concept of a platform for the healthcare as a whole, then the platform is open up for different players to contribute, whether the technology companies or the small players or the startups or the academia or the innovations. And this is a very important concept, same as the Google. So let's imagine that health also will be consumed in a platform. So in a way, then the provision of the care even can be enabled locally, it can be enabled internationally. You can tap into the knowledge, to the treatment from global dimensions. So, and this is what we're doing actually in Abu Dhabi, and we develop a concept what we call the orchestrator platform. So in a sense, we're bringing all the assets into one platform, and we're opening up the space as a marketplace for different players to tap into this orchestrated platform and develop solutions. So it's not going to be restricted to a specific kind of group or technology companies, but then whoever having an idea that they want to contribute and offer it to the market, they will be able to do it.
Mm-hmm. Have you seen any positive results from this?
Yes, we have seen. We're already testing it now, and we have seen a lot of, some cases where, first of all, some of the international companies, they are willing to engage with the data, not only for their use, but also to develop solutions specific to the system, more into offering decision support, for example, right? So you're taking the case of the case in here, for example, of the use of image algorithms and how to make it available as a decision support for providers and the physicians. So there are different cases, but if we have this rightly developed, the concept of a platform, then the collaboration becomes very open, and anyone who having good ideas and can contribute, then they can be part of the system.
Mm-hmm. That's an inspiring example when we are shifting to the last subject for this panel, which is collaboration. And we will first listen a bit to Sarah Thomas, who is Clinical Director for Are You Move at Are You, who is with us virtually. Welcome, Sarah Thomas.
Thank you.
The floor is yours, so to speak.
So thank you for inviting me to speak. And some of the topics that I've been asked to speak upon is a couple of questions that maybe you have for me. If not, I can just speak about the topics themselves.
Now I'm informed that you will present, so please do.
Okay. So I just would like to speak to you a little bit about the power of trusted partnerships for really, truly amazing outcomes. I don't have a slide text, so you will be listening to me for around 5 minutes. And I guess some of the things I'd like to talk to you about is about how Arjo sees are the real key success factors in achieving a trusted partnership. For many years, Arjo has been seen in the past as equipment manufacturers and providers of equipment. But just as the previous speakers and my panel guests also have been talking about, is that it's all about outcomes and measuring good outcomes. But there are some particular good critical success factors that Arjo consider are really important to have to create this trusted partnership. So for trust, there has to be reliability. So we deliver what we say we will. There has to be openness, especially in the joint sharing of information. And data, of course, we've heard a lot about data, and sharing data from customer to Arjo and Arjo to the customer is also vitally important. Honesty, and that's about being truthful and accurate. And also very importantly, competence. And so employing people in Arjo who are healthcare professionals, they may be nurses, they may be physiotherapists, occupational therapists, but very highly skilled with a lot of experience to do that job as a partner with that health facility. There's also a couple of other things. For 25 years, Arjo, we have been involving international clinical, ergonomic and health economic experts to make sure that we deliver only the best advice and collaboration with our partners. And this helps assure that trust that our partners have in us. And lastly, our outcome programs are a true partnership. This isn't just where the customer needs to trust in Arjo, but also where Arjo has to trust that the facility will play their part. And a lot of our programs is about cultural change. And so having the facility ensure that they are going to live up to that part is very important. So we really rely on each other and must really share and collaborate to achieve those desired outcomes. The second thing I want to talk to you about is about how we are able to see results in our partnerships and how do we know that our partnerships and our programs are successful. And I guess if I was to ask that question, the short answer would be that we measure results and the impact that we have. But as I said, this is around a cultural change program, and changing culture doesn't happen quickly. Often our programs and our partnership go over years, and it could be anything from 1 to 3 years. But over the past 20 years, we've had a proven track record with over 1,000 programs worldwide. Now, I know that longevity and the number of programs doesn't necessarily mean good results, but by us using rigorous assessment, measurement, care process mapping in very commonly undertaken care processes, like managing hygiene care, for example, or pressure injury prevention, as well as providing education, we've seen time and time again excellent patient mobility related results all over the world. And our program outcomes are focused in key areas for healthcare and always related to the impact of patient immobility. So, for example, improving operational and efficiency outcomes and also reducing financial cost associated with those health-acquired conditions. And we take a holistic approach looking at the facility environment, their equipment and resources that they have to hand, and the care skills that the caregivers, the nurses, the physios are adopting, as well as the facility internal processes and policies to ensure that the outcomes that are desired are actually achieved. And reducing health-acquired conditions and the costs associated with those conditions, such as pressure injuries, for example, are always in focus. So just to give a couple of examples, in a program I've been involved in Australia prior to the pandemic, of course, we saw a 58% decrease in caregiver work-related injuries, that's back pain, in the first 10 months. Now, that was considerable for this customer, particularly because prior to our program, our outcome program, which focused on reducing back injuries and back pain of their workers and reducing absences from work, they were more than twice the average of the rest of the typical hospitals in Australia. So they had a very high incidence of back pain and back injuries and a very high incidence of absenteeism and people off sick who were not able then to care for their patients. Now, in other programs, we achieved reductions in inpatient falls. So, for example, by 39% in a recent particular program, and also reduction of facility-acquired pressure injuries by 49%. And so something about our programs is that this isn't about looking to what we might deliver in the future, but these programs are around outcomes that we deliver today. And we are confident in our ability. We have a lot of experience, a lot of good results from, as I said, over 1,000 programs worldwide. And we are so sure of our ability to achieve this with our customer and with our facilities that we offer a guarantee on the outcome. And this really does help to assure our healthcare partners that we do really have their interests at heart and that we really do have skin in the game. And we're really confident of achieving those results. So thank you for giving me some time to speak.
Thank you so much.
I hope that gave you some insight into what we do in Arjo.
Absolutely. Thank you so much, Sarah Thomas. And that was a very clear message, I would say. I will actually turn back to the panel here now and ask, because if I refer to Sarah Thomas, as she says, reliability, trust and openness, data, honesty and competence is the key factors for good collaboration. I will ask the panel here, what is needed is something you want to add to that list when it comes to get a good collaboration between industry and society? Jenny, yes.
Maybe not so much add, but to a little bit elaborate what does it mean to have new competencies on board and new trust. And I think that during COVID we have learned that we have seen quite a new level of agile. So we had to work in an agile way. It was really data sourcing globally only that could have us. We had vaccines ready in 10 months. It's unprecedented. We have never, maybe in our whole lifetime, ever seen such a revolution. And I think that is really something to learn from. But we had to bring on board new actors in order to do so. And I think that this is really the reason, if I move a little bit beyond the problematic scene, this is really the reason why life sciences and healthcare is the place to be for the next coming 10 years. And that's why we also, data scientists, what do they want to work with? They want to work with data. What is massive data? It's not in space, it's not anywhere else, it's in life sciences, it's in our biology and our genes. But I do think that we have to work with the trust base and the collaborations with amongst other type of actors who can work with trust and data on that base too. I think that is really our way in moving in the future. And healthcare is extremely conservative. Now that if you're into making change, that's a good place to be, because if you want to make sort of a really to leapfrog something, you have to go into a conservative business in order to make a change. But then that boils back to trust, and that we actually need quite a slow-moving and rigorous system, because trust is not easily based, and it can so quickly be hurt. So we have to be safe and protective in that way, and still use the agile way of working that we've learned through COVID. And it was agile and safe at the same time. We've never had such good data in clinical trials before.
Yes, but there's also precaution. I saw a very interesting article in Science which had looked at citations and scientific reports, and they concluded that if you have many authors, they have large networks and they get more citations, but they are rarely that innovative. But if you are only one or two authors or something, you get less citation, but they are more probable to be very innovative. And I think that is a thing you can also put over here. So it depends on what you want to do. If it is incremental development of something you really know, then good, large collaborations is very good. If you would like to be very innovative and really look at things at new ways, I think small teams are the way to go, because big teams has to negotiate, and there are biases in teams and so forth, which means that they are not going to be that innovative.
Mm-hmm. Yes. Ma'am.
Yeah, I agree absolutely. Again, when we talk about such approach, after listening to those to our colleague, the two speakers, there is a very essential part where I think it will force the whole health system, regardless if they are provider or receiver in that case, is the patient-centric approach. So whatever we will be doing in IT and therapy, I think the concept of the genotype, the concept of ethnicity will be the front line. So I believe in a very near future, a physician will not be allowed by the insurance, neither the system, neither the protocol, to prescribe or provide any type of service without making sure that he understands the ethnicity and he did the proper test. And the same will be applied for pharmaceutical companies. Before coming forward and getting their clinical trials approved, there will be a consideration to look back at the percentage of ethnicity if it was considered during any stage of the 4 clinical trials, and if it is representing well the community. And I'll give another example which I believe it's so realistic to this part of the world. We had one of the medication, without mentioning the name, where they said it will treat any type of antiviral. While if you go back to their clinical trials, they were hardly somebody from this part of the world were involved genetically from a genotype. So we were not able to go ahead and approve, although it's approved. It's fine. It is approved by the ministry or by the authority, but it is not a drug of priority. So that company, they took another thought. They said, okay, can you be involved within that? So that's the concept of epigenetic and genotype will force everyone. And again, when we go to security, even that extent, because unfortunately for the past 100 years, Black people were always, unfortunately, labeled that they are aggressive and they are the one who will, unfortunately, will do anything like that. But right now, with all these technology, is showing us, regardless if you are black and white, still you are prone to do that. So again, the concept of ethnicity and genotype will be the other way around. Pharmaceutical company, IT, policy will come in place. And the last point which I would like to add after listening to all the presentation, I believe what will come to the system, again, when we say in the near future, it is within 5 to 10 years. Children will start suing their parents because with our understanding of epigenetics, where I came to know right now that the first 3 months of my pregnancy of my daughter, what I ate, the way I slept, the way my husband treated me, it will affect my children's health till the 100 years. So at that time, the children will have the right to sue their parents if they are not taking care of themselves. So at that itself, you know how nasty are the insurance system. They would like to have a reason where they can cover their costs from other source. So this is the new approach in health policy, which will come very soon in reality. And I believe, again, we as a young, lovely country, where we have 62% of our population are below age of 30. So we are trying our best to empower them with the right knowledge, how to take care of their child, so they will not sue them when they will be 40 years old.
Ooh. That's very thought-provoking, I would say, but okay, very interesting. So we need to sum this up, and actually, Niklas, you've been raving for a while.
I could start to give a kind of summary from my point of view. I mean, first, what Dr. Miriam said before, a little bit to your previous question here. I mean, difference is excellent. I mean, it's perfect to collaborate with different partners. And as you also gave the last example, with the collaboration that would be been avoided. And we are, you know, most of the examples that have been given today are from our work with Nordic Council of Ministers, and I have plenty of examples across the Nordics. But I think what you are saying, Anders, is very interesting about what is healthcare. What is actually healthcare? Should we broaden the concept of healthcare? And maybe it's easier to, you know, if you go to industry, when they want to make a giant leap, they don't try to transform. They try to build from scratch. Maybe it's easier if we build, coming from northern part of Sweden, building Region Västerbotten digital and Region Norrbotten digital. And once we have services that are well functioning and tested, then we start providing the services from a new track. Yeah. Maybe that could go easier. It becomes much more easier than to speak to the professionals that you need to transform. Because it's not easy to say that to anyone, and it's not good, because that is saying to them that what you are doing today is not good enough. You need to transform. And we need to be careful here, because the most important resource that we have are the healthcare professionals. I also like what Dr. Ahmed was explaining, the platform ID, that you try to create an open platform for use for development. And if we could combine all this, what very wise people have said on stage today, and also with the life science strategy that are very much in line in this, I think we're on the right track, not only in Sweden, but globally. And from our perspective, when working with you know, remote and rural healthcare, I think, because we see in Centrum have more partners across the world than if you ask our healthcare region Västerbotten, they don't know us, but we're quite famous across the world. So this is how it is. It depends on you collaborate with where you are known.
I think that will be the final word from this panel, and a very good conclusion as well. So thank you so much, dear panelists, for your great contribution for this quite hard subject, I would say, future. It's always a bit scary to talk about, especially when you get sued by your kids in the end. So anyhow, thank you so much. And I will now, while you leave the stage, I will welcome up our next speaker. Yes, absolutely. Because this whole day has basically been focused on collaboration, and so has this panel. And we have a very nice example of cross-border learnings, right? So I want to welcome Fatma Al-Yassim, who have been in Sweden, and you are here now. So please tell us a bit about your experiences.
Right, thank you very much. Last but not least, I'm not going to keep you long. It's been a long day for you. I'm going to take you through a journey of a few minutes. My name is Fatma Al-Jassim. I'm taking care of pediatric pulmonology in Dubai Health Authority. I'm an Emirati. I'm not going to talk about UAE healthcare system. Rather, I'm going to take you on a journey of my experience, sharing the Swedish health, my experience on Swedish healthcare system. I'm going to start with general reflections on the healthcare system in Sweden, and end up with some personal reflection that I would like to share with you on the Swedish healthcare system. There are many things that Sweden stands out in when it comes to in the Swedish healthcare system. The research system is an outstanding with leading publication worldwide. We heard earlier about the electronic patient records, which is far advanced in Sweden. The pharmacy and medicine dispensing, as well as infection control that you've been talking about the whole morning, and I can attest what Farida mentioned in the morning that you will be leading the ARM in the future. Also, the centers of excellence that are outstanding in Sweden, like the Oncology Center of Excellence, in particular pediatric oncology, being a pediatrician with a pediatric background, Center of Excellence in cardiology, cardiac surgery, and so on. However, I would like to point out one of the things that Sweden stand out in, that is communication. We do know that communication is a universal language that creates bond between staff, but most importantly with patient, regardless their background. If I had to mention one thing that Sweden stand out in is actually communication, with emphasis on communication skills, in particular with patients. I can recall very well the communication module I had in my training program back in Sweden, and I gained in-depth knowledge on the holistic Swedish healthcare system and emphasis on quality, value-based leadership, and patient-centered care. The next thing that Sweden stands out in, which I would like to share with you, is the patient-centered care. Everyone in the system back in Sweden worked towards this model with a lot of dedication. Everyone in Sweden has right to good and equal health care and access to sustainable care of high quality. The knowledge is the common ground, along with the aspiration to do what is best for the patients. The whole hospital system revolves around the patient. They take responsibility of involving entire healthcare, different system around the patient. Not only that, they create a secure environment for the patient and those who are around the patient, family, siblings, the whole family is being taken care of. Furthermore, healthcare workers work actively to explain things to the patient based on their abilities. Again, being a pediatrician, when it comes to children, I remember very well we were explaining to the children, not only to the parents, with pictures, illustration, fairy tales, parables. It's a way to reach to the children and make them understand their disease and what they are going through, and further on, take it to their siblings and friends. And Swedish healthcare systems, they have employees for everything. They have employees with a special focus, like, for example, family members, sibling, and also other parts of the patient's well-being, like school, kindergartens, and their surroundings. Sweden has a well-established integrated system, and that is thanks to a long tradition, a good collaboration between hospitals within the country. Everyone in Sweden, wherever they live, have equal right to a good health and good health care. Next is building and its surrounding. It is in a way made with focus on patient well-being and comfort. they have the latest, you have the latest technology and equipment. They are utilized in a way for patient well-being and comfort. Now I'm going to share with you some personal reflection. I had a life change. It took me to a life with huge responsibilities and great challenges. But as my master, His Highness Sheikh Mohammed bin Rashid said, the word impossible does not exist in our vocabulary. And that set out on this journey, and it shaped me to who I am today. The beginning was tough. It wasn't easy. And I moved to a country where I didn't know the language, I didn't know the people, and it was the boldest thing I had ever thought of doing it. I had a feeling mixed of excitement, but concern of unknown. It took me a while to get adjusted to the life in Sweden. I slept on the ice many times, but I got up and continued my journey, and it got easier along the way. Creating bonds was my help to adjust to life in Sweden. It made me feel I had something to belong to. It made me feel that I can associate with. And I still have these bonds connected, thank God. The Swedish language, all Swedes speaks great English, but then good command of Swedish language was crucial at that time, because Swedish is the working language used for communication with colleagues, especially with patients. So I was enrolled in the program, and I automatically came to the language institute called Folkuniversitet, where I was enrolled for the Swedish language. Following that, I obtained my medical degree from the Sahlgrenska Academy at the University of Gothenburg in 2003. And then I returned home to practice for a while, but I missed Sweden, so I went back. And then I continued my specialty in general pediatric, and I obtained the degree from the Queen Silvia Children's Hospital at the Sahlgrenska University Hospital. It was the same university in 2010. Following that, I moved to Stockholm, where I did my fellowship in pediatric pulmonology and bronchoscopy at the Astrid Lindgren Children's Hospital at Karolinska University Hospital. So this is the end of my presentation. I would like to thank everybody in Sweden for the amazing years I spent over there. I feel as much at home in Sweden as I do in Dubai, and that's really so. And I always remember my academic professor who was always telling me, Fatma, I'm not going to teach you, I'm not going to spoon feed you, I'm not going to teach you how to do things, I'm going to teach you how to think. And I have this in my mind, and that's why what I enforce to my residents as well. Finally, I learned how to extend bits of goodness everywhere I go. Thank you very much.
Please stay, please stay. And thank you, Fatma Al-Yassim, for very nice reflections. First, I must say that the picture of the parking lot, that's a horror picture, even for Swedes. So we get that clear. But
that's life in Sweden. That's reality.
But now you almost only positive things to say about Sweden in this presentation. But please give us some advice. What can Swedes do better that you have reflected on?
Okay. Being honest.
Yes, that's what we do.
Apart from the horror picture.
Yeah. Can't do as much about the weather.
Yeah, it was very cold, minus 20 degrees. Whatever clothes you put on, it doesn't help.
That's true.
You
can't
freeze.
do much about that either.
You really freeze. Loneliness. But actually, I took it in a positive way. Sometimes you need to be alone, and I learned how to be alone in a positive way and how to dedicate the time for yourself. You don't need to be surrounded by people all the time and most of the time. Sometimes you need to be alone. And this is what I tell my family very often, I need to be alone.
Oh, you became Swedish.
Yes, very Swedish. After spending almost 16, 17 years in Sweden, so I'm half Swedish.
Yes, that's absolutely true. Well, Fatma Al-Hashim, thank you so much for your reflections and warmly welcome.
Thank you for having me
you
here today. Thank you.
And Anna Ribe, it's time to sum this day up and please give us some final concluding thoughts. You've been listening and working a bit, I know, because it's a lot of work behind the scenes here going on.
Yeah. No, I just want to say that I'm so extremely happy to be able to stand here in the beautiful Swedish pavilion after more than 2 years of planning and seeing happy faces here and knowing that there are people watching and joining us digitally as well. So I think today we've been talking about the challenges that we have with chronic diseases, with infections and AMR and aging populations. But I think the interesting and dynamic discussions that we have had today really show that we can work together and we can share experience, and that will help us to tackle these challenges and also to make the best use that we can of the opportunities that we actually do have within digitalization, within precision health and medicine, patient focus. And I also want to add staff focus, because staff is very important. And also through collaborating. So I think this is the way to go. We should continue to build bonds, as Fatma said. And before inviting you to the reception, where I hope we can continue to build these bonds, I would like to give my thanks to the audience that has been here today, quite a large crowd. We've had more than 250 people joining us at a single time in the digital audience, so thank you very much for joining us. Of course, I want to say thanks to the excellent speakers that we've had that have taken their time to share their experiences and their knowledge with us. And of course, the moderators, Ingrid and Frida, very well done. And then all the people behind the scenes, I think you have been really amazing. So now I just would like to invite you to enjoy some small talk, something to eat, something to drink in the reception, in the lobby and on the rooftop. And just a big thank you to all of you that are here today and virtually or physically.
And come back tomorrow at 10 o'clock.
Yes, and also if you want to continue discussion, do so on our LinkedIn page. And if you want to, follow up, let us know and we can organize more, maybe webinars or in the future seminars where we can meet again. Thanks
for today.
This is the world of HemoQ, the global leader in point-of-care HB testing. Why are we the global leader? Because we understand that healthcare professionals don't just measure the HB of a patient, they meet the needs of a patient, wherever it may be. It's about quality, accuracy, and trust. Our systems are reliable and robust, and they deliver accurate results in a wide variety of tests. But our dedication to innovation, quality, and reliability also means we pride ourselves in a supply chain where customers, healthcare professionals, and ultimately patients depend on our global presence. Of course, that also includes best-in-class customer support, from education to repair centers. We're committed to the delivery of high-quality testing at the point of care, because that's who we are, a company passionate about meeting the needs of your patients.
I believe that we are in very exciting times in the history of life science. We are now analyzing and characterizing all the building blocks of human beings. The most important building block is the proteins. Traditionally, it has been very hard to do this in a very comprehensive way, but there are now new technologies to do this. And one of these technologies is proximity extension assays. And this allows us now to analyze in a very sensitive and accurate way a lot of the proteins which are present in blood. And that is why I'm so excited about the future.
Olink Explorer will be a game changer for proteomics. This new development combines our elegant PEA technology with a state-of-the-art NGS platform. I find it exciting that we've now reached a higher multiplexing level and that we're also using a semi-automated protocol. And with that, we can achieve increased throughput, but at a lower cost.
Smile is a non-for-profit business incubator. We help entrepreneurs develop their business ideas and build successful companies within medtech, diagnostics, biotech, and e-health. With over 300 years of combined industry experience, we offer our members top-of-the-line business coaches and a large international network of industry experts and investors. Since the start, Smile have coached 100 companies to success. 90% of these are still thriving, and 20 have launched an IPO. I am extremely proud of all these companies. They represent different areas of life science, but they have one thing in common. They all contribute to a future of better health.
Care is already made for the patient. After that, the patient will be referred to the Center of Excellence when they are found fit that they can give a complete detailed information what is required for the particular study. This is the reception counter where the patient will come from the OPD and get registered in the Center of Excellence for further counseling process. From here, the patients will further move to the cabins that are created, and there are different sets of cabins created, including the physical rehabilitation, psychological counseling, nutritional counseling, and palliative care counseling points. So after going through all these cabins, the patient will submit all the documents. There are different domicile forms also for each and every cabin on which the patient, according to the patient's requirement, questions are added, which will be answered and assessed on follow-up, that how the counseling is improving the quality of life of patients.
So they have to be told about their disease, how it progresses, the possible signs and symptoms, the causes of cancer, can cancer be prevented, and frequently asked questions